Hello and welcome to our video on mass transfusion protocols. My name is Mary Siki. I'm one of the PGY2 general surgery residents at Washington University in St. Louis. I'm joined today by Dr. Brian Kidd, one of our cardiac anesthesia and critical care attendings here at WashU. He did his medical school at Southern Illinois University, went on to his residency in anesthesia at UNC in Chapel Hill, and then came to WashU for his cardiac anesthesia and critical care fellowship. And we're so lucky he joined us as faculty. So thank you so much for being here with us today.
Thank you for the introduction, and thank you for having me. It's a pleasure.
Yeah, doing my research for this discussion, I sort of had a wide variety of definitions used of mass transfusion, running the gamut from just 5 units of red cells all the way through to multiple uses of blood product. Do you have a definition that you like to use and framework of thinking about mass transfusion?
I've seen a number of different definitions used. I've seen the examples that you mentioned. I've also heard commonly used 10 units of red blood cells or other blood products. I think what's less important than what actually meets the definition for consideration for massive transfusion is recognizing the massive transfusion protocols that we have as systems and tools to make resources available so that for patients who are massively hemorrhaging, we're able to get them the blood products that they need in a timely fashion.
And so, what about specifically cardiac and vascular surgery patients make them at high risk for needing a lot of mass transfusions? And are there certain surgeries where you've seen patients who really are kind of needing those large quantities of blood and blood products?
I think it's worth pointing out that virtually all surgical procedures that we do could potentially put patients at risk of massive hemorrhage and require massive transfusion, but ones that come to mind are certainly aortic procedures, both open and endovascular. Also, various thoracic procedures, lung transplantation, where it's maybe encountered less often than one might assume would be open cardiac procedures using cardiopulmonary bypass, where blood is salvaged through suction, cell saver, and help from our perfusion colleagues.
Do you have a decision tree or kind of mental framework that you like to think about when you're approaching a patient who you think may or may not be in need of blood products? Does that differ in the operating room versus in the post-operative ICU resuscitation period?
I think, yes, there's a lot of nuance that goes on, differences between those settings that you described, but I think it's important to simplify some of that decision making as far as are we bleeding? Is there coagulopathy? Could both be going on at the same time? And is this expected blood loss? Is this a procedure where at one point or at one critical step we can anticipate losing hundreds or even a liter at a time, but will quickly be controlled? Or is this going to be an ongoing issue? I think anytime that a patient requires more than 2 units of blood transfused, it's probably time to at least ask yourself the question: are we heading in the right direction, or are we heading towards a clinical scenario that is likely going to require more products to be given?
Any adjunctive tests that you're using to kind of determine whether a patient needs reds or platelets or plasma, and sort of how do you direct your transfusion from there?
Sure. I think that we have some good evidence to support what our transfusion thresholds should be, recognizing that for most patients, transfusing for a goal hemoglobin above 7.5 is a probably reasonable place to start. But in examples of massive hemorrhage, where real-time hemoglobin levels might not be indicative of absolute values of blood loss, some of these decisions are made more empirically, and that's where we get into ratios of products. Best evidence we have is that resuscitation, closest resembling whole blood, is probably best. Although we're an institution that's fortunate enough to have whole blood available for example, our trauma surgical patients. It's not necessarily available for all patients across the board, and so being ready to give products in a 1-to-1-to-1 ratio.
Are there any diminishing returns to continuing, massive transfusion? Are you worried that maybe there'll be surgical bleeding that you have to go back?
In the ICU setting, I think that's one of the first questions that I'm considering is this unrecognized surgical bleeding that requires a surgical intervention, or are we possibly just behind on resuscitation? Is there a coagulopathy that has recently worsened? So certainly obtaining the appropriate lab values, but also early communication with our surgical colleagues. I'm not trying to keep that information to myself, as I am not wanting to be responsible for reopening a fresh sternotomy at the bedside myself. It's getting all the invested parties involved early so that decisions can be made. Whether that's to mobilize resources to return to the operating room, whether that's I think early communication is critical in coming to the right decisions in these situations.
Well, thank you so much for joining us today and sharing your wisdom with us. And thank you to Hemosonics for sponsoring this video content. And stay tuned for more content from TSRA and Hemosonics.
Thank you.